I presented two abstracts at American Academy of Neurology. One was oral presentation, and one was the poster presentation. So both studies are based on the same methods, the same single study, which is an observational open-label cohort study. We're looking at the role of Galcanezumab in prevention of migraine. And we used e-diary throughout the study, so we were able to capture the headache features as well as the frequency. We included patients, adult patients from 18 to 65 years of age, who were diagnosed with either episodic, 18 to 14 days per month, or chronic, 15 or more days per month, migraine, according to ICH-D3 criteria, which is the golden standard for diagnosis of migraine. Diagnosis was based on the 4 weeks diary. So we had a 4 weeks diary, so we can go back and check and see and diagnose the patients. We recruited 64 subjects and or patients, and we had 43 participants who completed the whole 4-month e-diary and were scheduled for the final visit. So we defined the responders to treatment. We call them Galcanezumab responders, according to the percentage of migraine days or decrease in percentage of migraine days by 50% during the 3 months period. Now, for the that was for the one study, and for the other study, we also looked for the super responders, and they were defined differently. So they were defined as super responder was patients who had decreased migraine days by more than 70% during the 3 months treatment period, and the super non-responders were those who did not experience decrease by headaches and had less than 30% during the 3 months period at the assessment time. So we had several visits. We had initial visit where we recruited the patient. We had collected the information, did the tutorial on, for example, how to do the e-diary, explain them what the quantitative central testing is, which is essentially the method of testing the pain sensitivity in humans, and to instructed, educated about it. And then we had a baseline 1-month diary, and then at visit 2, we reviewed the diary, and they were administered the medication called Galcanezumab. And they took it for 3 months, and at the end of the 3 months period, we reassessed them. So just to mention, this project is much larger than what you see now in these 2 projects. We actually follow the patients longer, and we also do some imaging data. So more data is going to come on the future meetings. So we're looking forward to presenting this data in the future. I'm going to now focus on the first study, which I presented as an oral presentation. The title of this abstract was Pretreatment Cephalic Intractable Allodynia Predicts Outcome of Prophylactic Treatment of Chronic and Episodic Migraine Patients with Galcanezumab, which is a QST study. So here we looked at the intractable part and why. So previously we showed that allodynia during the headache phase, we call it ictal allodynia, which is a manifestation of central sensitization, determines the outcome of acute treatment, like it's typically with triptans. In this current study, we made a hypothesis that it's non-ictal rather than ictal. It means that the allodynia in between the headache attacks that determine the outcome of the prophylactic treatment with Galcanezumab, and will tell us about the responses. So why Galcanezumab is important? Because it's a new novel treatment for migraine. It blocks the CGRP molecule, and in this way, it blocks the CGRP pathways and results in reduction in pain. It's a very popular treatment now, a new treatment for migraine. And by doing that, we'd like to understand also the pathophysiology of migraine. We also want to understand how these medications are working, how we can predict their responses. So I told you a little bit about the methods. And so as I mentioned to you before, we used QST, which stands for quantitative sensory testing. It's the ultimate method to assess the presence of the allodynia in humans. You can assess it both cephalically around the head region or extracephalically in other than non-head regions. It could be like in the arm, could be on the leg, etc. And we use the criteria for allodynia, the following criteria, which we based on the previous studies, less than 40 degrees Celsius for heat, that they were having the allodynia. If it was more than 20 degrees Celsius for cold stimuli, then they had allodynia. Or if it was less than 60 grams for fond fry hairs, they were defined to have an allodynia. And so what we did is that we identified 24 patients as responders and 19 as non-responders in the study. So it means that 24 people had at least 50% response rates after 3 months treatment with Galcanezumab. Majority of these patients, of responders and non-responders, were female, which is reflecting the distribution of migraine, according to the gender and sex in population. The age of patients were around 33 to 34, and they experienced migraines for anywhere between 15 to 17 years. The headache frequency was anywhere between 13 to 16 on average, and their BMI was 24 to 25. So when we compared the non-responders to responders, we did not find any significant differences in age, years with migraine, migraine days per month, or BMI. So they were very similar groups always. So now going to the results, so what we found that incidence of cephalic allodynia in responders were much less compared to non-responders. It was 79% had no allodynia in responders, against 10.5%. And allodynia was present in 89.5% of non-responders, comparison to 21% in responders. In other words, the allodynia was highly prevalent or highly frequent in non-responders in comparison to responders. We also looked at the extracephalic allodynia. In the extracephalic allodynia, we found similar trends, but we could not find significant differences. So in our conclusions, we said that cephalic allodynia is a better predictor than extracephalic allodynia for Galcanezumab response. Now, when you did a QST, you actually used the heat, cold, and mechanical stimuli. So what we actually looked at to see if there were any differences in allodynia to specific stimuli, to the heat, cold, or mechanical. And we found that that the cold allodynia was also significantly more prevalent in non-responders in comparison to responders. This was also the case for the mechanical allodynia. We did see the numerical differences for the heat stimuli, but we didn't see the significant results. What we did is we'll also look at the rate of response. So non-ictal, non-allodynic patients demonstrated 86% response rate to Galcanezumab, whereas the non-ictal allodynic patients demonstrated only 24% response rate to Galcanezumab. So to conclude, what we now have learned that the presence of non-ictal allodynia can be used to identify responders to Galcanezumab with nearly 80% of accuracy, and Galcanezumab non-responders with nearly 85% accuracy. So there are some implications of this results for both in clinics and in research and understanding of the mechanisms of the migraine. In clinics, it will help us to predict response rates in the future. And when we see the patients in our clinics, when we decide what to prescribe and what to expect from the treatment. Mechanistically, the presence of a non-ictal allodynia in both chronic migraine and high-frequency episodic migraine raises the possibility that the non-ictal allodynia may be attributed to physiological properties of central trigeminal vascular neurons, which could be partially due to genetic load of the individual patients than their actual migraine frequency. So this was this study about the ictal allodynia. So the other study, which I would like to also talk about, it discusses the prodromes and triggers. As I already mentioned, the title of the abstract was the Galcanezumab effects on the incidence of headache after occurrence of triggers, premonitory symptoms, or aura in responders, non-responders, super responders, or super non-responders. So here, the aim of the study, was to determine whether the incidence of premonitory symptoms that followed by the headache decreased or remained unchanged in patients with the migraine frequency. And we also looked at to see if triggers are no longer the triggers for the headaches, or they can predict the headaches. Again, the same study. The only thing we added here was with the super responder and non-responder groups. So we looked at more in that. And what we found in this study is that, again, we had 64 patients, and we had 46 of them which completed the 4-month e-diary and did not miss any single treatment cycle. And we had 27 patients who were classified as responders, and we had 11 as super responders, and 19 as non-responders, and 8 as super non-responders. At 3 months of Galcanezumab treatment, what we found, I'm just going to summarize here now, is that incidence of prodromes followed by headache decreased by 48% in responders against 28% of non-responders, and in 50% of super responders versus 12% in super non-responders. In other words, the incidence of prodromes decreases with the treatment. And the second finding was the incidence of visual and sensory auras followed by the headache reduced among the all groups, with except of super non-responder group. The number of triggers followed by the headache also decreased by 38% in responders against 13% of non-responders, and number of triggers also decreased in 31% of super responders in comparison to 4% of super non-responders. If you look at the premonitory symptoms, the incidence of headache following the cognitive impairment and irritability, which is very common premonitory symptoms, reduced in responders and super responders only, whereas the incidence of headache after fatigue, nausea, and vertigo reduced in all groups except of super non-responders. When we looked closely at the triggers, the incidence of headache following not drinking enough or being too hot reduced in responders and super responders, whereas the incidence of headaches after stress, sleep, and light reduced in all groups, with the exception of super non-responders. So very interesting results, which is, shows us that in this observational study, the peripherally acting drug, we know that CGRP monoclonal antibodies works peripherally, not centrally, in migraine, reduce the incidence of headache occurrence after the common premonitory symptoms and triggers in those patients in which migraines were reduced by more than 30, 50, or 70%, but not less than 30%. There are several potentially interesting suggestions these findings can give us. That some premonitory symptoms and triggers are secondary to hyperexcitability and hyperresponsiveness that developed in neurons that receive prolonged and continuous painful signals from the meninges, which is the pain-sensitive structures in the brain, and that even the mild attenuation of these pain signals is sufficient to restore the normal sensitivity of neurons and neural circuits that mediate these premonitory symptoms and triggers. Another thing that was very interesting finding from the study and gives a little bit of additional thoughts is that the findings provide further justification for lowering the definition of threshold for responders from 50% to 30%. In other words, we're right now using 50% as a cutoff score for response, but we may need to reconsider that in the future studies and lower it to 30%. I can tell you that we're looking also on longitudinal data to see what happens at 6 and 12 months. So we will be presenting them soon after we have done our analysis. We're also looking at to see what's happening to the brain, both functionally and structurally, after this treatment.